Welcome to this episode of the Chad G Ortho OT podcast. I'm your host, Chad Guerrero, and today we're going to talk about what to expect after a knee replacement surgery. So, a lot of times people get very confused with this. There's been a lot of kind of misconception as to what this process is or how tremendously painful it is and this long road to recovery. And so, really, what we're going to kind of go over is most of that is not accurate. That's kind of old information. So, when I first started practicing, 20 years ago, yes, you see the patients in inpatient hospital settings, whether it was PT and OT and all this kind of stuff, and they're working with patients, range of motion, and oh my goodness, it was all these different things. They had to get a certain amount of range of motion before they could go home. Maybe 90 degrees, had to be able to bend the knee and flex it to 90 degrees before they could go home. And these patients are just stretched out on the mat, just being tortured. It looks like. And then there's all these other aspects of it. They had to be able to do things like dress themselves and bathe themselves and all these different things before they could go home or maybe walk so far. And nowadays, the way that that's done is much different. So you typically what will happen with a knee replacement, also known as a total knee arthroplasty, and there's kind of several approaches with this. The physician can, the orthopedic surgeon can do what's called robotic assisted. They can do it just traditional. A lot of times now, the physicians or even the post surgical procedure, there's different things they're doing. You used to always send you home with those CPMs, continuous passive movements machine. And so all that's different now. So we're going to go over that. That typically what happens is you're going to have the knee replacement surgery. Now, there are some physicians that are sending their patients for prehaps. They're going to therapy for strengthening, go ahead and kind of prep everything as much as you can before you have surgery to try to lessen your recovery time afterwards, and maybe your range of motion is better and your understanding and expectation of what's going to kind of go on is much better, and so you're more confident after your surgery. And so that will happen in a lot of cases, but you're going to have your surgery. And what's typically going to happen is if you're a pretty high functioning patient as far as your mobility, maybe you just have knee pain, but you still can get around. You don't have a lot of other comorbidities health wise. And so a lot of times you're going to have the surgery and you're going to go home that day. You may stay overnight in the hospital sometimes, but typically not. You're going to go home, and then you have usually two options. And those two options are going to be you're going to go to outpatient therapy right away, usually the next day, or you're going to have home health services again right away as fast as possible. And then for the patient that maybe doesn't have a lot of support at home, or they have a lot of morbidities, or a lot of other health issues, then maybe they're going to go inpatient somewhere, what's called a skilled nursing facility. And those patients will go in there straight from the hospital. They're going to go into that skilled nursing facility. And just like the other two options of either home health or outpatient therapy, they're going to start the exercises, movement, all of that stuff right away as fast as possible. And again, you're going to stay, depending on what your insurance allows. If you're staying inpatient in a skilled nursing facility, that might be where you stay, 30 days, or maybe you stay 2 weeks and then you transition from a skilled nursing facility then to maybe home health, or you go from a skilled nursing facility to outpatient therapy. There's a few options there, and that's going to depend a lot of times on what your insurance allows. Again, when I first started practicing, insurance would let you, stay inpatient for longer periods of time, or stay on home health longer, even outpatient therapy longer. And a lot of times now they're very strict on that. They can be, just depends on the insurance. And then, you're going to have to really focus on your home program and things you're going to need to do at home, on your own. But if you go with the home health route, now that's not a bad route. I've done a lot of home health in the past. I worked a lot of home health, both part-time, full-time for a little while, kind of while I was transitioning to get ready to open my clinic. And so with home health therapy, the limitations there are is the therapist is, number one, limited by time. They don't have just a ton of time that they can spend in a lot of cases. And the other thing is equipment. Now, I always carried not just like all the exercise bands and dumbbells and different things like balance cushions and all these kind of things, but then I also carried portable, NMES units, or like neuromuscle electric stim units to try to, work on retraining muscles and all that. So I carried that with me typically my entire home health work that I ever done. I always had those on me, and just to try to kind of jumpstart the muscles and get them back going. And so that's one of the limitations you're going to have in a home health setting is there's not going to be as much equipment. Although at first you don't need just a ton of equipment because the biggest thing is they're just working on range of motion, restoring that quadricep or thigh muscle strength and activation as quick as possible. Because anytime that you have knee surgery or knee injury, the thigh muscle kind of shuts down. It gets immediately weak. You didn't lose muscle fibers, but just that's kind of the brain prioritizing, working on the healing of the injured knee, because even if it's a surgical procedure, the brain still perceives that as an injury. It's a threat to the body. So it focuses on that. And so you're going to lose muscle strength immediately because you'll notice, you had knee surgery. Prior to knee surgery, you could pick your leg up, your whole lower extremity, put it over in the bed, and that might be painful, but you could do it. And then you have knee surgery, and guess what? You can't even pick your leg up, your lower extremity up, because it's all weak. And that comes from, part of the quadricep muscle or the thigh muscle that crosses the hip joint, the rectus femoris. And so some of that just causes those muscles again to kind of shut down or tone down the dial, so to speak, on the energy that's going to the muscles. And so you want to try to restore that as quick as possible. And then, of course, you're going over things like your walking and falls prevention. You want to make sure that you're doing plenty of walking, you're using your walker correctly, because a lot of times you are going to be on a walker initially. And you're going to use that walker, rolling walker, where you have the wheels in the front and the back. A lot of times people put tennis balls on that. So you're going to be using that initially for a little while, not for a long time, but until you get the control back of your lower extremity. You're going to want to use that for falls prevention purposes, especially because something else to keep in mind here is you're going to have some numbness, your loss of sensation. A lot of times around the knee and the thigh, they're going to cut through the lateral cutaneous nerve. So you're going to lose some sensation there. Not to mention just the surgical procedure in general throws off the kinesthetic awareness, those sensors in the tissue that gives information to the brain, kind of the cortical mapping, or like kind of what everything looks like and feels like, and how you adjust. It's kind of like how where your extremities are in space. You don't have to think a lot of times, if you don't have any issues with a nervous system or an injury, where is your leg, where is your arm? You just kind of know. And so that gets disrupted. And so you want to make sure that you kind of start to restore that as soon as possible, but you have to be careful. And that's why you're going to use the walker because that's all kind of disrupted for a little while. So as that gets better, then you can get off the walker and then transition maybe to a cane, or maybe you don't use any kind of other external assistive device to walk with. You just start walking. That's fine too. Also, if you are in the home health setting, you may get sent home with what's called a CPM, continuous passive motion machine. That's where you've probably seen someone, they put their, they have their lower extremity in that kind of strapped in, and it's set to a certain degree amount. And then that's moving, the lower extremity, bending the knee and then straightening the knee and then bending it. And you'll use that for several hours a day. So it just depends on physician preference with that. Some physicians, believe it or not, will actually send you home with, it's like a kind of a fixed knee brace all the way from the upper thigh down just above the ankle. And there's one doctor in particular that I know of that sends patients and the knee is locked out straight. It's completely straight because he feels like it's important not to lose the knee extension. So being able to straighten your knee all the way, because that's very important not to lose that. And, he feels like it's easier to regain knee flexion when you bend your foot back underneath you. And so he would rather focus on making sure that we get that knee extension, and then we can work on knee flexion. Also, you may be sent home with like this kind of electronic bicycle. There's these sticky pads that kind of go on the side, and it's all electronic. You can adjust the range of motion and all that. You kind of hook up to it, and you can use that as well. So a lot of different options with that. I don't think there's any one particular that's the best or correct, and it's just physician preference. I've been really lucky over the years to work with some great physicians for all sorts of different joint replacements and orthopedic repairs and all that. So I've not really had any trouble with any of that. So it just depends on physician preference with that. And so now if we're talking about outpatient therapy, you go straight to outpatient therapy after your replacement. What can you expect typically day one? Well, number one, if you had surgery, let's say the day before, you're coming in the next day. A lot of people are, they're apprehensive of that. They're nervous of that. They don't know what to expect. How hard are they going to push my knee and stretch my knee and all that, because we have to get it moving, because you don't want scar tissue to set in. and make that knee stiff. And something I also remember is before the physician closed up the surgical procedure. So you're in surgery. Before they close everything up, they took your knee and they bent it all the way back. So your foot was bent all the way back, straightens all the way out. So that there's all that movement happened before they close it up. They're going to close the knee up. The reason you're going to lose a lot of this range of motion, number one, is because of swelling fluid, and the other is going to be because of muscle tone, muscle guarding. So you're going to lose it because some of that, and then also just the brain, the apprehension of pain. You're nervous about it hurting. So there's several factors there that are going to play in, and that's what's going to cause the knee to become stiff and a little difficult to move. So if you go to outpatient therapy, usually the first thing you're going to do is start doing some range of motion movements, and that's usually you're going to do some of those movements, and then the therapist is going to help you kind of go through some of those as well. They'll probably do some passive range of motion or passive stretching. That's where the therapist just completely, you just try to relax, and the therapist moves your knee, kind of bends it, and then straightens it out all the way, and just go through some movement with that. And typically, like for me, I usually just go to what the patient can tolerate, and then we push maybe just a touch more. Because if I said, okay, we're going to go through here and we're going to bend your knee to 120 degrees, which by the way, 120, 125 degrees is considered functional. And anything 130, 135, if you can get that far, is just bonus. And so that's great. And so a lot of therapists are used to, you just shove it back as hard as you can. And so again, we just go as far as you can tolerate. If you can tolerate a little more, that's fine. Go a little farther. And then, just because if I go in and be really aggressive with it, or the therapist goes in really aggressive, you already are nervous that this is going to hurt. So you may start, having some muscle guarding, and you kind of tense up, and you just don't relax all the way. And so the movements, not only is the therapist having to fight against maybe the muscle tone and all that, but then they're also fighting against you, just kind of holding back, not letting them go through that range of motion. So they're going to do range of motion movements. And then if the clinic has access to modalities like electric stim, I like to put the electric stim on, get on the quadricep, on the hamstring, anywhere we can start getting that activation of the muscles. And so what I really like to do also is not just have the patient sit there and not do anything. So they're going to actually contract the muscles while the electric stim is going. I think you get a better contraction that way, just a better kind of a mind muscle connection. We also use biofeedback systems. I use the M trigger system, which I love. And that, again, just helps to kind of retrain everything and get it all kick started back to going. And then you're going to do, work on walking, again, using assistive devices. Make sure you know how to use your walker correctly, or your cane. Go over some fall prevention things. If you need to have education and training on how to dress yourself, especially your lower body, you're probably going to have to sit to perform upper body dressing. So going over safety things with that, kind of how you need to be doing a lot of those things. How to transfer in and out of the bathtub or the shower. If you have steps or stairs at your house, you can practice that, especially if the clinic has a set of stairs. You can kind of practice that, going up and down, and kind of showing you if you have a walker, or you're using a cane, or whatever that is, just to kind of how to manage that safely. You're going to go through all those things. And then usually this is kind of a slow process for the first couple of weeks. And then after this first couple of weeks, things start to really speed up, and the pain does get better. And then you just kind of go from there. You start really adding in more strengthening exercises, what's called motor control exercises. You're doing all those things to really get everything back going, adequately. A couple of things to kind of remember that you want to be careful of is putting a pillow behind the knee. Now, a lot of people, the knee hurts, feels better to bend the knee just a little bit, keep it bent. But if you put that pillow behind your knee and you leave it like that for extended periods of time, then you could limit yourself from getting that knee flat, that terminal extension. It's very, very important for the success of your knee surgery that your knee will go flat. And so just, remember we talked about, some physicians, or one physician I know of that puts patients in that fixed brace and keeps them, very fixed and the knee out straight. So you don't want to lose that extension. So that's very, very important. So I tell patients to put pillows or something under the calf area, and kind of let the back of the knee kind of float. So if the knee is, you've got it on one side and you're just kind of letting that float, and like a, suspension bridge, and let that behind the knee kind of stretch and come down. And you're going to also notice behind the knee that gets very tight. There's a muscle back there called a popliteus muscle, and it crosses kind of sideways, so to speak, or diagonal behind the knee. And what it's responsible for is when your knee is out straight, it helps to unlock the knee, because when you extend your knee out all the way, at the very end, there's a little bit of rotation, what's called external rotation. And so your tibia is going to externally rotate just a little bit. And the knee is a hinge joint, so theoretically it only moves in what's called the sagittal plane, so straight frontwards and backwards, just flexion and extension. However, there is a little bit of rotation that does occur when you kick your knee out. If you notice, if you're at home and you just kick your knee out straight, you're going to notice your foot kind of turns out a little bit at the end. And then if you're sitting and you pull your foot back underneath you, you're going to notice that your foot turns inwards. So whenever you flex your knee, you're going to notice a little bit of internal rotation. So that little muscle in the back of the knee will get tight, and can have some adaptive shortening over time. So you want to make sure that you're really stretching that out. And then we also do a lot of soft tissue work, massage, and all that in that area. Of course, you have to be careful because of blood clots. That's also something to watch for, is the blood clots. A lot of times you'll come home with one of those compression garments and you'll wear that. Sometimes you will, sometimes you won't. You're going to be maybe on a baby aspirin or some sort of blood thinner medication or something. So that's always something to keep in mind, especially if you're a therapist and you're going to do soft tissue work, massage, and all that. You want to be cautious of that, and aware if the patient's on blood thinners or if they have a history of blood clots or a recent blood clot and all that. So you just want to be aware of that. Because a lot of times if you have that blood clot, it's not just normally, it's not just a slight pain or discomfort. It's very painful. It can be warm to the touch, can be red, reddened in that area. It can be hard. You palpate it, you push on it, you may feel a hardness. And so over my career, I found a couple of blood clots in that area, behind the knee and the calf area. And in my experience, it's been very obvious. There's a test you can do for that called a Homan's test that you can do, just at home, but you'll go, you want to follow up with your physician or go to the emergency room either way. And they're going to do like a Doppler or a D-dimer, different things like that to try to determine if you do have a blood clot going on, and then just address that. It's in a lot of cases, they can do some things for that and get it calmed down. It doesn't turn into a big ordeal, but you definitely want to let them know. So that's just making sure that the knee, is flat. The other thing is don't get discouraged if you have periods where maybe one day your knee has 100 degrees of flexion. You can bend your knee and the therapist is getting 100 degrees of flexion, and maybe the next day they only get 90 degrees. Well, as long as you're being really active, you're going through your exercise program, you're walking, you're doing a lot of things at home, just expect that the byproduct of all this activity and moving and all that is going to be some swelling. So it's kind of go up and down for a while. As long as you go 2 steps forward, if it goes 1 back, 2 steps forward, that's okay. You don't want to go 2 steps back and 1 forwards. And so that's normal to have that, that kind of back and forth sometimes for a little bit. You may have periods where you go a week or two and there's not a big change. And so maybe then all of a sudden you make all these gains the next, week 3. So that's not uncommon either to have that where it does kind of go up and down for you. And again, the pain with this, in my experience, and yes, there are a few patients that it's been difficult for, but in my experience nowadays, the pain is so much better. The recovery is so much better, so much faster. Sometimes it's not uncommon to have a patient come in, they had surgery a day or so before. Maybe they had surgery on Friday and they're going to come on a Monday, and they already have 90 or 100 degrees of flexion, being able to bend that knee back. Remember, we were looking for 120, 125 or something greater than that. And so that's incredible. And that's no aggressive pushing or stretching. That's just them coming in and doing that on their own. So again, it's much, much better than it used to be. So you don't have to be so nervous about it. And then your therapist is going to give you all these different home, exercises and things that you need to be doing at home, maybe a walking program. A lot of therapists now are big on backwards walking. So you kind of walk backwards. You have to be careful of that. You want to make sure you have some good control of the thigh and all. I'm a fan of that too. And I think that works, especially if you're having a little bit of loss of that extension, getting that knee flat. That works really well. And don't be surprised also that if your knee, the outside of your knee, around your knee stays, numb, you have loss of sensation there for a while, completely normal. And that will either come back. In some cases it won't. It may take a year to come back, may take longer. A lot of times, a lot of my patients are told by physicians that don't be surprised for the first 1 to 2 years if it takes that long to recover. Just get those final touches in before maybe the knee stops swelling all the way, or you feel comfortable where you can maybe tall kneel or get down on your knee if you need to, maybe a deep squat, something like that. That's not uncommon. It's also not uncommon if maybe your knee wasn't popping or clicking or making kind of a little noise, or you kind of sense there's a popping or clicking or something. Sometimes that happens. It may not happen at first. It may happen over time. That in most cases that's normal. Now, if you think there's a hardware issue and the knee feels very slackened or loose, and you definitely want to follow up with a doctor on that. But that's not all that common, really. So don't be alarmed by that. If you have like just some sensation changes that you feel, or just or different things that you hear kind of with the knee joint. So again, all simple stuff, really. The procedures, they're so fast with them now. They're so good with them now. The recovery is better. So you don't have to be super worried about having your knee replacement, because in most cases, they do very, very well. So I hope this episode helps, guys, to kind of give you a little bit of an idea about what to expect if you're thinking about having a total knee arthroplasty, also known as a knee replacement. Thank you so much for listening. Be sure to rate me 5 stars wherever you listen, and we'll see you guys next time. Thanks so much.